It's my distinguished honor and privilege to introduce our speaker for this afternoon session, addressing a topic which I believe needs to be front and center of this conference. I would not pretend or deceive you to think that an hour session of our lunch is going to tell you everything that the community needs to be involved with, or their roles in human research protection. But I will tell you that we need to find a way to bring the community into this discussion. The session that just ended was a nice segue into this one. Especially I enjoyed Dr. Sharp's comment that many times when we're talking about what does community cares about, as people who live in the academic world, we think mostly about compliance. To the community, compliance is important, yet they want to know that there are policies and committees and structures in place to ensure that people play according to the rules. But it's more than compliance. It's about trustworthiness. And if we cannot bring communities into these discussions with the goal of establishing trust, it's almost that all the things we've talked about are diminished. And it gets all the more complicated when you think that when we talk about community, it's not just one community. Whether it's ethnic communities, it's not just one community. So I'm hoping that you are in for a very engaging and interesting presentation this afternoon. Our speaker is Dr. Vanessa Northington Gamble, who is an MD, PhD. She is a university professor of medical humanities and professor of health policy and American studies at the George Washington University. She is the first woman and African American to hold this prestigious endowed faculty position. Dr. Gamble is also professor of health policy in the Milken Institute of School of Public Health and professor of American Studies in the Columbian College of Arts and Sciences. Dr. Gamble is adjunct professor of nursing at the University of Pennsylvania School of Nursing. Throughout her career, she has worked to promote equity and justice in medicine and public health. A physician, scholar, and activist, Dr. Gamble is an internationally recognized expert on the history of American medicine, racial and ethnic disparities in health and healthcare, public health ethics, and bioethics. She is the author of several widely acclaimed publications on the history of race and racism in American medicine and bioethics. Public service has been a hallmark of her career. She has served on many boards and chaired the committee that took the lead in successful campaign to obtain an apology in 1997 from President Clinton for the U.S. public health syphilis study at Tuskegee. She is a member of the National Academy of Medicine that was formerly known as the Institute of Medicine and a fellow of the Hastings Center. On a personal level, she is a proud native of West Philadelphia. Dr. Gamble received a BA from Hampshire College and a MD and PhD in the history and sociology of science from the University of Pennsylvania. Please join me in giving a warm Minnesota welcome to Dr. Gamble.
Thank you for that warm introduction, especially since it's here in Minnesota. I lived 10.5 years in Wisconsin, and once there was a group of people who asked me what I consider coming to Minnesota. And the response was, why would I come to some place that's even colder than Madison? But I'm really happy to be here today. When I was coming in yesterday, can you hear me, Steve? Okay, they said they can't hear me in the back. When I was coming in yesterday, I said, the limo driver asked me what I was doing here, and I told her. And so she says, what time's your talk? And I said, it was at lunchtime. And I said, you know, that's one of the worst times to have to give a talk. And I said, dinner might be even a little less worse too. And she said, why? I said, you know, people are more interested in their food and talking to each other than listening to me. So I'm here talking about tough duty, trying to be between you and your desserts. Fortunately, I don't eat desserts, so what I'm going to do today is I'm going to provide an overview of the growing importance of community-engaged research in medical research. I'm a historian, and as a historian, I always want to say, why are we here at this moment? You know, 20 years ago, we were not talking about community-engaged research the way we are today. And to discuss some of the opportunities, tensions, and challenges in conducting community-engaged research, and analyze some of the ethical issues in community-engaged research, especially in communities of color, and to examine research in the context of changing community demographics and contemporary politics. Now, the last thing that Kola said when he read my bio sketch was, I'm a proud native of West Philadelphia, and I went to Penn. And I want to start there because I grew up in the shadow of an academic medical center. I was actually born in that academic medical center. I was born at Penn. And I grew up in a community where my family has lived for 4 generations. We were poor, but we took care of each other. We were a community where yes, we had our problems, but we had care and nurturing. It was not until I got to Penn that I realized that the community was a problem, that I was one of the community people. And I'm like, yes, but I didn't know what a community person meant. And in that context, it usually meant someone who was non-compliant with therapy, somebody who was not well educated or was problematic. And the reason I wanted to start here today is, one, to let you know who I am and what I do. But my growing up in West Philadelphia has driven my life and my career. So I am here not just as a scholar, but as a community person. Okay, let's talk about the growth of community-engaged research. As I said, you know, why are we talking about it now? And I see, you know, a few things, but let's talk about what's meant by community-engaged research. And community engagement is the process of working collaboratively with and through groups of people affiliated by geographic proximity, special interests, could be religion, or similar situations to address issues affecting the well-being of these people. It's not what we were talking about today in terms of individual clinical research. We're talking about working with and through communities, which is a very different paradigm. And so I want to talk about why there has been this growth. And I think there's 4 reasons. Federal mandates, some of the initiatives to eliminate racial and ethnic inequities in health and healthcare, funding opportunities, as Jeff Bodkin said this morning, that, you know, money can be a good incentive, and community demands. Let's start with federal mandates. The National Institutes of Health Revitalization Act of 1993 was designed to address disparities in the participation of clinical trials. And it was to get more women and minorities included in clinical research. So, in working with communities of color, that it was this act that helped trying to diversify clinical trials. But sociologist Stephen Epstein talks about what it has also done is something he calls recruitmentology, which is a new field of empirical study that seeks to develop scientific evidence about the best way to successfully enroll the so-called hard-to-recruit populations. And we hear a lot about these hard-to-recruit populations, you know, talking about trust, talking about being culturally competent to try to get more people of color in clinical trials. And I'll say some more about that later. Another factor that has led to the increase in community engaged research are some of the initiatives to eliminate racial and ethnic diversity, inequities in health and healthcare. Now, I want to start here, but I'm going to go off point for a few minutes to talk about one of my pet peeves. Bear with me for a second. I spent 3 years at Tuskegee University being the head of the bioethics center there. And one of the things that being at Tuskegee really got me very adamant about is the use of the term Tuskegee to just mention the syphilis study. That Tuskegee University has done more than be involved in a syphilis study. If you're lucky, people might know about the airmen. And then, you know, a few years ago, Lawrence Fishburne was in a HBO movie about the syphilis study and then about the airmen, and then some people thought that airmen were in the syphilis study, so it got, you know, it really got things really confused. But the reason I say this is that there was a history of helping Black people in terms of healthcare at Tuskegee Institute and later university, which people don't know about because all they hear is Tuskegee syphilis study. The other thing is, when we did some focus groups, that people thought Tuskegee had done all the work for the syphilis study. They were involved, yes, and no one knows about the Public Health Service. So, President Clinton apologized in May 1997 for the syphilis study at Tuskegee, not the Tuskegee syphilis study. So I just wanted to, even though that's a little off point, if you have a microphone, use it. My mother said always, speak up. And it worked until I used it against her. Now, anyway, so the survivor, so one of the things that the reason that those of us who fought to have an apology was some of the issues that have come up earlier about lack of trust in communities of color about research. And so we thought that in the African American community, having the president say he was sorry for the syphilis study would be an important step. And at that meeting, at the apology, President Clinton directed Donna Shalala, who was then head of Health and Human Services, to issue a report that how best to involve communities, especially minority communities, and research in healthcare. And there were some other initiatives that came up in terms of racial and ethnic disparities and communities. The Reach 2010 initiative that was in 1998, and that supported community coalitions in designing, I want to start there, designing, implementing, and evaluating community-driven strategies. So it's not when a researcher comes in and said, look, we've done this, what do you think? Is that being at the table at the beginning. And in the report that came out after the apology for the syphilis study, the community's report was enhancing community participation to restore trust. So the focus is not just on individuals, but communities. There were other partnerships that came up. one of the things that has driven a lot of the work in racial and ethnic inequities is the work that David Satcher did when he was first at CDC and then at Health and Human Services, and helped President Clinton to establish a race and health initiative in terms of trying to eliminate these disparities. Healthy People 2010, which I was involved in the late 1990s in terms of trying to think of what would be the agenda for healthcare in the future. And that also emphasized community partnerships. So that so thinking about community, the importance of community, has developed part and parcel with the growth of the interest in eliminating racial and ethnic disparities. The Institute of Medicine report that came out in 2003 that basically showed many, many studies that showed that in this case, mostly focusing on African Americans, that the quality of care, the lack of access to care that people get because of the color of their skin. And what was very interesting to talk with people when this came out was people would say, I always thought it was about insurance. But their studies have shown that people of color with insurance getting into the doors of our academic health centers are treated differently. So one of the things that the work in disparities has shown is, and this is the Grim Reaper at the door of a black man saying, you'll be happy to know that race played no part in this decision. Now, those of us who do work in racial and ethnic inequities know that race is the Grim Reaper is going to come for all of us, but when the Grim Reaper comes is based on your race and ethnicity. So now there's funding opportunities. In the NIH Clinical and Translational Science Awards and the TCSA's programs, it has part of its mandate that engaging communities in clinical research. PCORI, which is a Patient-Centered Outcomes Research Institute, also has funding grants. And also in NIH, the National Center for Advancing Translational Sciences has grants for doing community engagement. Also community demands. There have been problems with, and Jeff brought this up earlier, in the Havasupai Indian tribe case where biospecimens were misused and community had not given consent for their uses for a wide variety of reasons. They thought that they were doing a diabetes study, but it was used for other studies, including schizophrenia. And so some Native American tribes now say that if you won't let us review the research before it's done, you can't do research in our communities. So we have federal mandates, initiatives to decrease racial and ethnic disparities in health care, and community demand and funding opportunities. Why, at this moment, we are talking about this. So there's a continuum of community engagement mechanisms, and this is from the principles of community engagement, which comes out from the CTSI. And you see that it goes from outreach. Remember the old outreach? You go and it's almost like being a missionary. Sometimes you just go out, you're there to help the people of color, and then you feel good until the next time you're feeling charitable. And so there's some community involvement, all the way to where there's shared leadership. Several years ago, I was doing a site visit for the Robert Wood Johnson Clinical Investigator, Clinical Scholars Award. And they said they wanted people, the new scholars, to be involved in community engaged research, and that we had to evaluate the centers on that. So we go to some site visits, and it was clear that some folks, they just met when they put the grant together. Or they might have met that day. You know, it was clear, and I see some knowing nods out there. You know, it's like almost like let the church say amen. That it was clear that there was no real collaboration. There was no shared leadership. We went to another site visit where there were members of the community running the site visit. And being as skeptical as I am, I knew the two community folks. And I said, you know, at a break, oh, tell me, you know, is this real? And then I said, you know, is this just for this grant? You know, is this you just showboating, or you just? And they said, no, it's real. And one of them is out in Los Angeles, is a very active community organizer. She says it's real, but it took time for us to get to the shared leadership model. It took time. It took some folks getting their feelings hurt. Sometimes it took going back. Sometimes it's admitting that it was a failure, but continuing to go. So that's one of, you know, doing community engaged research is very, very difficult. It's very time consuming. And something that Richard Sharp said earlier today, which is true, not a lot of people are doing it well. I don't know any model that say this is the place that's doing it best. But people are trying and people are working at it. So I just want to show you what are some of the models. Here's another way of looking at the community engaged research continuum. Less community involvement where it is predominantly investigator driven to complete community involvement where it's community driven research. This is what PCORI talks about when it talks about engagement in research. It encourages awardees to engage patients and other stakeholders at every stage in terms of planning the study, conducting the study, and disseminating the study. This is from the President's Commission for the Study of Bioethical Issues, and in 2013, they issued a report on community engagement. And engagement allows community members to articulate concerns or priorities, to be able to say, this is something that's important in our community, or I don't know what this is all about. Why are you here talking with us about this? Express concerns. Identify vulnerable populations within the communities. Because one of the things, I was going to get to this later, but I think it's a good time to talk about now, is what's meant by community. How are you defining community? Aren't academic medical centers in a community? Because sometimes it's like it's the us and them. I mean, so usually, you know, that even within the communities around academic health centers, that it's not monolithic. And it's not just how you are defining community, it's how you're framing communities. Is the definition that hard to reach population? Or is the definition of the group that's the problem, lives in the bad neighborhood? So, I mean, it's perceptions of communities and also definitions of communities. And also having community members can also help identify implications or complications of the consequences of the research on the community. And it also allows the research participants to consider more thoroughly the risks and benefits. The other thing that the Presidential Commission does not talk about, but I firmly believe, is that it also allows the communities to be teachers of the researchers. That the community has assets, they have knowledge, they have information that they can teach to the researchers. So this cartoon is, you can see I have a New Yorker subscription. They're harmless when they're alone, but get a bunch of them together with a research grant and watch out. That's how some folks feel about research and researchers. So here is the voices of some community members. Researchers come into our community, they study us, they get what they want from us, and then they're gone. We're left with the same thing we had, whether it's obesity or environmental diseases or what have you. You come in, you write your papers, you get your grant money, you go away, and nothing here changes. Sometimes it's even worse. So the question of for whose benefits? Whose benefit is the research for? Is it for someone just to get their grants, their promotions? Or is it to improve the lives and the health of communities? Here's another one. Why am I in such demand as a research subject when no one wants me as a patient? Now, we can spend a lot of time deconstructing this one. Because you can't get health insurance, you don't have a physician, but someone wants you as in a research protocol. So let's talk about some of the challenges. I already talked about the definition and framing of community. The other thing is, how do you move from the focus, which was so much a part of this morning's conversation, of moving from an individual to moving to working with a communities? What should that relationship look like? We heard this morning about some of the ethical codes, about the Belmont principles. What should be the principles when you work with communities? Do we take the Belmont principles and just try to revise them, as some people have tried to do? Or do we need a new set of principles? So a lot of the things I'm raising today are questions that need to be answered as we move forward to working with communities. And what measures are needed to increase IRB competence and community engaged research? Now, we heard this morning about some of the, some of the issues. But what happens when you get community engaged research there? What happens when you have a junior faculty member who's involved in community engaged research, and it takes time, as I said, and they won't get as many publications done? Or the promotions and tenure committee does not know how to deal with a portfolio that has community engaged research. This is the one that I mentioned briefly. Are the Belmont principles adequate? Or even if they are expanded? Yale's CTSA tried to do this, and so they took the Belmont principles and added community, respect for community. What's the impact of the research on the community itself and recognition of the diversity of community perspectives? If you do research on, say, a sexual transmitted disease in a particular community, is that community going to be, as was in the syphilis study, where Black people were thought of as a syphilis-soaked race? So what's going to be the impact on the community? Beneficence. Should the research, how does it benefit the community or harm communities? And justice. So sharing of benefits. Sharing of leadership, sharing of results. Many times community members will complain that they came in, they did the research, and we never heard anything else. What happened with it? In terms of some of the other ethical issues do communities and individuals need to consent for the research? So how do you identify the community member? Is it the person who has the loudest mouth? How do you select who is the community representative? As I said, what is community, how do you select these folks? And what are their roles? I mean, some places have community advisory boards. Others have more community engaged research boards. How do you control the power? There's a power dynamic. How do you control that? What are some of the mechanisms to alleviate that? And I'm going to spend some more time, shortly talking about trust. PCORI says these are their guiding principles of community engagement: honesty, transparency, reciprocal relationships, co-learning, partnership, and trust. Let's talk about trust, because it's a critical component of community-engaged research. Now, Ruha Benjamin, who's a sociologist and a bioethicist, talks about we need to depathologize distrust, especially when we talk about communities of color. Because many times we talk about communities of color as that they are inherently distrustful. And she says we need to stop thinking of it that way. Now, I'm always amazed when I hear bioethicists talking about the reasonable person. Because my question is, how are you defining a reasonable person? What objectives are you using? Whose criteria are you using for a reasonable person? Okay? Well, for some people, I want to use that today. But for some people, being a reasonable person might not, you might, in your experience, has led you not to trust the medical center or other community institutions. So that I think that we have to think about it in terms of, there are different categories of trust. So a person can trust their physician, they can trust the nutritionist, they can trust the nurse, but still not trust the institution. You might trust the police officer who helped you last night, but you might not trust the police. So that I think that we have to, look at these and break them down. Bioethicist and chaplain LaVera Crawley says we should talk about trustworthiness. And that if we keep focusing on distrust in the minority communities, it promotes the stereotype of people of color as distrustful. But she also defines distrust as a breach of trust. That institutions need to ask, what have you done to deserve trust? Not to expect trust. So I just want to talk some about building trustworthy and sustainable relationships. Acknowledgement that people's history can make them be reasonable persons and not trust medical institutions, and the importance of community attitudes and history. That if you are an undocumented immigrant, that you might think the hospital is representing the state. And the need for community engagement and consultation during all stages of the research, again and again and again. You need to demonstrate the benefits of the research to the community. That it's something to the community that you're not bringing to them. And this whole thing of viewing this as a long term. Acknowledge that everybody is bringing some type of expertise. Understanding the priorities and expectations of each partner. Frequent and continuous communications. So let's talk about research in the context of changing community demographics. Because one of the things people said, let's use cultural competence. Let's use cultural competence as a way of getting communities of color in research. I want to say that the US Public Health Service syphilis study was one of the most culturally competent studies there were. And this is a definition of cultural competence. Because the study, as many of you know, went from 1932 to 1972. It was a study of untreated syphilis sponsored by the Public Health Service. They use things that, think about when you're thinking about your clinical trials. Use the black church, go to a black school, use black investigators. So that I want you to think about that there are some ethical challenges in talking about cultural competence. that it can also lead to exploitation of communities. I'm starting to think more and more about cultural humility. And it is a form of communities and physicians and hospitals working together. It grew out of conflict, this model. It grew out of the Simi Valley verdicts, then in terms of after the beating of Rodney King, where there was riots all over this country. And Children's Hospital Oakland said, we need to do something about this. They created a multicultural health office, and two pediatricians there developed this model of cultural humility. And the reason why I like this model is that it says that we all have to commit to self-evaluation. We all don't know it all. That we have to be humble, show humility when we go into communities. And it focuses on developing mutually beneficial partnerships. And it's not like competence, it's not a discrete endpoint, but a commitment to active engagement in a lifelong process that individuals enter onto an ongoing basis. Now, my final New Yorker cartoon. And it is the elephant in the room. And it's like, it says, I'm right there in the room and no one even acknowledges me. So I'm going to talk about an elephant in the room. And this, how do we do research in the context of the Black Lives Matter movement? So earlier this year, Mary Bassett, who is head of the New York Department of Health, wrote an article in that very radical journal, the New England Journal of Medicine, talking about Black Lives Matter, a challenge to the medical and public health communities. And I urge you all to read it. Because what Dr. Bassett, who talks about her work, but also as her life as a mother of Black children, that she powerfully and eloquently wrote about the strong moral and professional obligation to encourage critical dialogues and actions on issues of racism and health, and also to reach out to our communities. Because if we are serious about eliminating racial and ethnic inequities, we cannot just use a medical model. That one of the things that has changed as I've done this work is that we are now talking, not just, I used to spend all my time talking with medical people about inequities. Now I spend time talking with criminal justice folks, income inequality folks, educational inequality. So that when you think about working in communities, it cannot just be about healthcare. We need to think about this broader. And being at an institution such as the University of Minnesota gives you the options with work of all people from different areas and disciplines. So the community is a source of strength. It's a source of knowledge. It's a source of expertise. And if you're seriously interested in doing community engaged research, you have to come in with that attitude and not like, we're from the government, we're here to help you. So my final slide is from a very well-known philosopher and bioethicist, Cedric the Entertainer. And Cedric the Entertainer says, what are you going to do about it? And I'm going to change that as what are we going to do about it? Thank you very much.
I think we have time for a couple questions. Just to indicate by raising your hand if you have a question.
Questions, that's great.
Yes, there's a hand up there. Let's get the microphone.
Okay, I'll shout it out. So at the risk of asking a politically inappropriate question, I understand, the definition of community readily in the case of, let's say, the Okuyemi, where there are 650 members, well-defined. But I worry about the definition of community if it's not a discrete and insular community, if one empowers the community to restrict access to that community around research. How do you define that? It's one thing to say, well, it's in Harlem community, or is it, Ashkenazi Jews for other kinds of research questions that impact that group, and how do we go about defining community so that it's robust, respectful, but still allows members within it to also have an independent voice?
Well, first of all, one of the things I said is that you have to define the communities, and it's not carved in stone. So yes, it could be Harlem, but it could also be Latinos in Harlem. That's a distinct community. And so that's part of the discussion on what you are looking at. I think a lot of times, it's interesting that you said to allow members of the community to have an independent voice, because right now, they're not seen of having independent voices. And like a part of this is that they can disagree, because it's like a lot of times, I think now they're seen as a monolith. In that part of this process for each of the different studies that you might do is how are we defining our community? How is the community defining itself, which might be in conflict with what the health center. Also, community could be patient advocates. That it could be, your community could be people who are looking at a particular disease. That's what a lot of the PCORI work is about. So I think that that community engaged research is here, and that as part of that process is the whole definition about it. So one of the other ethical issues is, that it can come up, say here in Minnesota, you have a Somali, population. What happens if you have someone who's an interpreter working in a research, and you find out something that about a group member that you know because it's a small community? So that those are some of the challenges in working with communities. And I don't think it's a politically inappropriate question, but the thing is, what I always find is that people ask that about communities. How do you define community? But, today we heard so much about research ethics and about some of the ambiguity about that and working to try to make it better. And it was seen that that was acceptable to do. But that sometimes when people talk about communities and stuff, it's like, well, how can I do this? So that's where I sometimes have problems with folks.
Yes, we'll take one more question, and then I'll read one from the webcast. Yes.
Yes, my name is Sandra Crump, and I have a question about engaging community prior to funding. Do you have any suggestions about how you can get community involved prior to funding so that you have them in the leadership role from the beginning?
I mean, that's when some of the people who are out there on the ground running start talking about having connections with different groups in different communities before a research project. That it might be about working on improving a school. It might be so that people are seen before in various communities if you want, and how you, how people are in various communities beforehand. So then then you might also find out what the community's healthcare needs are. What are their interests? And before you write, the grant. So a lot of people, that's why I said it has to be broader than healthcare in terms of getting, these connections. You want to read that?
Yeah, so this is a question from the webcast. As researchers, we cannot always do right by the communities with whom we work because our grants come and go. How can this be addressed ethically and with integrity in community-engaged projects, especially early/pilot stages of research, when long-term sustainability and benefits to the community are unpredictable at best?
Right. Let me say, one of the things is that, this is a challenge. This question brings up some of the things that happen when you have a short-term grant and it's a pilot. And that's why I think it's important to have sustaining commitments and working in community that's just not focusing on one grant. And so that you stay, you might be doing something else working with the community. One of the things is, public schools in this country are in bad shape. So what about having a program to help kids in education as you're doing your research? As part, not just you, but the institution, so that it's not seen that you're just there for this one study, but you're there for the long-term benefits of a particular community.
Well, I wish we have more time, but please join me in thanking Dr. Gamble.